And good evening, everyone. It's Dr. Bill Tullo, Chief Medical Officer at Oculus, and welcome to the Oculus Clinical Webinar Series. Tonight, I'm extremely excited to welcome our guest speaker, Dr. Ariel Cerenzie. The title of our presentation is Precision Without the Guesswork, Transforming Your Specialty Lens Practice with the Pentacam AXL Wave. Before I introduce Dr. Cerenzie, a little bit of housekeeping. If you have questions during tonight's webinar, please place them into the chat. We'll do our best to answer all the questions at the end, and if we run out of time, we will certainly answer them via email. Dr. Ariel Cerenzie is a specialty lens and myopia management enthusiast. She's the owner of Charlotte Contact Lens Institute and the Raleigh Contact Lens Institute, practices solely dedicated to providing specialty contact lenses and myopia management care. Dr. Cerenzie attended optometry school at the University of Houston College of Optometry and completed a cornea and contact lens residency at the University of Missouri St. Louis College of Optometry. She's a fellow of the American Academy of Optometry and the Scleral Lens Education Society and the secretary of the Piedmont Optometric Group. Dr. Cerenzie loves spending time with her husband, James, and her children, Sophie, Adeline, and Owen. Her favorite hobbies include water skiing, mountain biking, and weightlifting. Without any further ado, welcome Dr. Ariel Cerenzie. Take it away.
Awesome. Thanks, Dr. Tullo. And thank you so much for you guys inviting me to present on one of my favorite instrument in my practice, the Pentacam AXL Wave. I was really excited when I was asked to present on this. I'm a big fangirl of my Pentacam AXL Wave, and I joke that if there was ever a fire in my building or an emergency, I would take her with me down all 7 flights of stairs. So really excited to talk about how it has really transformed my specialty lens practice at the Charlotte Contact Lens Institute and then at the Raleigh Contact Lens Institute. So a little bit of background, Dr. Tullo mentioned that I did a cornea and contact lens residency. Afterwards, I went into private practice for about 3.5 to 4 years. I really enjoyed private practice and being able to see just the full gamut of patients. You know, it's something really exciting about seeing a 70-year-old, glaucoma patient and then walking to the next room and seeing a 6-year-old myopia management patient. And I found my days where I felt most fulfilled and most energized at the end of the day were days that I got to see specialty contact lens patients. So I decided to open my own practice. So first opened the Charlotte Contact Lens Institute, and it was really important to me to have one really good technology. I wanted to be able to fit anyone that walked into my practice that their eye could handle a contact lens. I wanted to have all of the options available to me. And so when I started this practice, I knew that I had to have the Pentacam AXL Wave. And we'll talk about the many reasons why that was the case as we continue to go on in the presentation. Then a few years later, started the Raleigh Contact Lens Institute. So we really kind of set up the framework for the Raleigh Contact Lens Institute. But Dr. Madison Moss is the doctor at that practice. She's the one that makes all of the magic happen at that practice. And she's been doing an incredible job there. But we really love our aesthetics and our plants in addition to our technology. So why did I choose to have the Pentacam AXL Wave? Well, for a lot of reasons that have to do with specialty contact lenses and my efficiency in fitting these types of lenses, everything from sclerals to ortho-K to corneal gas permeable lenses. We know that the Pentacam is the golden standard for monitoring, diagnosing, and treating anterior segment disease. And when you have one of these, you really have kind of like a lot of clout from other doctors that you know what you're doing. You're taking it really seriously. I remember when I first opened this practice, this was one of the things that I really talked to potential referring doctors about is, hey, I have a Pentacam. I will be able to monitor this patient for any sort of progression of their disease. get them back to you if they require any sort of like cross-linking, if they were a cornea specialist, for example. But also in making sure that these contact lenses weren't causing any issues with their corneas or their overall eye health. So it does a lot of things, and we'll see. I'm going to actually show you guys a patient that I scanned last week. It's a matter of like less than 2 minutes, and it gets so much data for you. The things that were of particular interest to me when I was first thinking about getting this was aberrometry. It does AR for you, and then so much more than that. You can get your total aberrometry, your lower order aberrations, as well as getting a look at what the higher order aberrations are of the eye as a whole. But also you can separate the cornea from that and see what aberrations are coming from the cornea. Kind of moving past to the highlighted areas, shine fluid tomography. So most of you that are on this webinar probably know what that means already, but just for completion's sake, we're getting the anterior surface information, posterior, and everything in between without having to rely on tear stability or any sort of dye being placed into the eye, which is great because a lot of these patients have really unstable tear film when they have, these really irregular corneas. And then big one also for me was getting to see scleral profilometry. I wanted an instrument that I could view the sclera, the shape of the sclera, and know what type of lens I should fit for the eye from a scleral lens perspective. And I also wanted an instrument that I could use with multiple different labs versus having to be married to a few different designs. Then lastly is the axial length or the optical biometry. Being able to monitor my myopia management patients with an objective measurement like optical biometry was so important for me. I feel like it's just a piece of data that's really helpful for being able to determine your treatment success or lack of success. And then recently, the myopia management software that was incorporated, which we'll show a little snippet of later, was really critical to being able to educate patients from the beginning on kind of where their kids fall in the axial length growth chart, as well as how their treatment is doing with time when they come in. They're always really excited to see that. So we really feature our Pentacam AXL Wave on our website, so patients are educated about it before they come in, along with some of our other technology. So we really talk about why our practice is different with this device, that we can really create contact lenses that are designed specifically for their eye, that really excites patients when you talk about these like hundreds of thousands of data points that we take in order to design a truly custom lens for them. And then that education continues in the exam room. We have screens everywhere. This is Dr. Sipperly. This is the doctor that is my work wife at Charlotte Contact Lens Institute. And we have a big TV in the exam room where we can review images with patients. We have 2 big monitors in each of our exam rooms. This is Dr. Moss, where we'll have patients review their images alongside with us. So we really just kind of carry the education from the beginning till throughout the exam, and then even while we're doing the scans, which we'll walk through how we do that education as well when we do our live patient in a moment. This is a cool backstory. My mom, so she's from Germany. She moved here when she was 20, when my dad took her away from all of her family and moved her to the US. They met while he was in the military in Bad Kreuznach, which is kind of by Frankfurt. So when we were in the process of building this practice, I knew that I wanted the Pentacam AXL Wave, and I thought, well, heck, I am probably an hour and a half from their headquarters. I wonder if I could go, just like meet some people and tour their headquarters. Well, I didn't know that I was going to have the opportunity to meet Christian, their CEO, and David, who's the Associate Director of Clinical Applications and Product Management. They were both so nice and showed me the entire facility and just welcomed me with open arms. And I waddled around their facility. I think I was like 7 months pregnant, and really enjoyed it. It was really cool. Fun fact is that that acuity chart, what they call it, like the land belt rotating C, or I forget what the heck they call it, but that is the largest VA chart in the world. So you can go up however many kilometers away and test your acuity on top of a little hill there. It was pretty cool. So let's talk a little bit about the acquisition. So what you can see, I'll go ahead and restart that, is there's going to be 2 rotations that are taken with the CSP scan. One rotation is of the cornea, and then the second rotation, it's getting the scleral lens data. So let's walk through, if you are on the doctor side of things or the technician that may be taking this scan, all you have to do is go into the corner here, and you're going to select new full sequence. And from that, it's going to take you through a series of these scans. So we'll see exactly what that looks like. But what I do want to mention is I'm the one that takes these scans. I don't have a technician that helps me with them. So being able to get really good data on a patient from being able to open up their eye all the way is totally doable with one person. Yes, it's easier if you have another person on board to help out, but as you'll see as we go through this, we got these scans in less than 2 minutes, and this was an actual patient. So you can definitely do it with one person. So the first thing that we did is biometry. That's the first on the list. You have a little patient view here where you tell the patient what they should be seeing and what to focus on. Then you just line it up, and it starts to get your measurements. So once we get that, we can see that we have our AR reading, our auto refraction, but there's so much more that we'll get from just that quick, 10 seconds that it took all of that information, which is the aberrations that we'll get to see a little bit later. It's also going to show us the retro illumination. So if somebody has like a big, cortical spoke, for example, we may be able to see that in the retro illumination feature. Okay, so now for this, what we're doing is I've asked the patient to keep their chin in the chin rest and their head against the headrest. I'll ask the patient to then just reach around the little bar of the headrest and hold their lower lid down ever so slightly. I'll ask them not to pull it way down because then it makes it hard to hold their upper lid. So hold it down ever so slightly, and then I'll reach around the device and hold their upper lid. So that's what's happening right here. I will also put a little bit of anesthetic in their eye. That way their eye isn't drying out, and I'm like trying to fight them from blinking during the scan. So this is when we see the two rotations that happen. And then I'll kind of turn the screen around for the patient to see it. And I'll say, just then we were able to get so much data. We got 25 cross sections of your cornea, which is here. And then the light dims a little bit so we can get the profilometry of the sclera. So 25 cross sections looking at the scleral profile. So what you can see here is it told me that I got about 100% coverage of that 15 millimeter cord. You can get out to about 18 millimeters. You can see that my quality score, it flagged it a little bit. So I'll check that. And it's flagging this 3D model deviation. It should be less than 14. Mine was 14, so I said, good enough. I'm fine with that. So then I click finish, and let's see, it has been 1.5 minutes so far. So then I'll kind of chat with the patient about what we just did and then all of the information that it's going to give us from here. And then what will happen is we'll see this corneal scleral elevation map. And I'll spend some time talking with the patient about all of that data and what that means for us in the lens fitting process. So for this presentation, we'll primarily focus on scleral contact lenses. I would have loved to be able to talk about GPs and ortho-K, and I'll be able to touch on them at the end, but I didn't want to make this webinar last 2 hours, and even though I would love to be able to talk more about those, but maybe next time. So why is the Pentacam AXL Wave so helpful with scleral fits? Well, there's many reasons, but I'd say the main one that I've found a pretty significant difference in really speeding up my chair time is not dealing with these challenges as much as I used to. So challenges like redness, pain, discomfort, fogging, difficulty with removal. What do all these things have in common? The edges, typically. It's usually always a problem with the edges. We can't ignore the limbus. You know, the limbus is important too. So that's probably maybe like the second hardest thing I feel like with the sclerals. It's relatively easy to figure out what to do with the cornea. We just have to vault over it, right? And try not to vault too much over it, not too little. But for the most part, aligning with that scleral profile is probably the most challenging part of fitting scleral lenses. And why is that? Well, that's because it's pretty variable depending on what meridian you're in and how far away from the limbus you are. So this is some data from some of these brilliant people here, some of them out of Pacific, Pat Caroline, Randy Kojima, and then Abe Vanderwerp, just, you know, the celebrities of the specialty contact lens world. And this was back in 2013 where they were looking at the bulbar slope at certain cord lengths. So from 10 to 15 millimeters, they found that the slope was, you know, had some variety to it, but wasn't too significantly different. So if we look here at the superior nasal, we have 37.7 degrees, and then inferior temporal 39 degrees. And that's just how much the slope kind of deviates from that horizontal plane, where if we have the steeper, the more elevated that typically is. But once we get out to further from the limbus, we start to see that there is quite a big difference in the slope, overall slopes in the different semi-meridians here. So if we look at the same superior nasal, 36.6 and then 43.2. So that's pretty significant when you think about a scleral lens landing in those areas and how different those profiles and that overall height would be. This was kind of another way to look at some scleral shape characteristics that is pretty interesting, where they looked at the periodicity of the different groups of, I think they had like 100, what was it? I wrote this down so I would remember. It was 140 eyes who all underwent corneoscleral topography. So it was Dr. Denayer. He categorized them into four main categories. Group one would be folks that really didn't have much variety between the highest and lowest point of scleral elevation. And that was about 6% of the group that he studied, meaning that you could put a scleral lens on that had spherical haptics and that lens would align pretty well. Group two was, you can kind of think about it how we describe patients corneal astigmatism to them, where we say, instead of you having like a basketball that's cut in half for a shape of a cornea, you have a football where you have a flat meridian and you have a steep meridian. This is kind of what that group 2 is like, where we have a flat meridian of the sclera and then a steep meridian, and it has a periodicity of about 180 degrees. So for about 29% of patients, you could fit them in a toric lens and they would do pretty well. Now, group 3 and 4 is where it starts to get a little bit more complicated, where there was more than 300 microns of sagittal height difference between the 2 lowest or the 2 highest points. So you can see how 180 degrees away that the height differences were pretty significant. And that would require a quadrant specific lens. Then a quarter of the population that he looked at had conformed to no rules. It was just kind of all over the place. He went on then to look at patients with different locations of ectasia, and based off of where, like the more peripheral their ectasia was, the more quadrant specific effect they tend to have. So that's a lot of information to think about. And you really don't have to think about it if you can just measure their, if you just have your CSP data. I remember during residency, Dr. Julia DeKinder was like, if you don't have a topographer, kind of the poor man's way of measuring a topography of a patient's eye is put a spherical GP on. And you can see here, this is a GP that we put on a patient, and you can see like the elevation, that the cornea is more elevated here. You technically, I guess, could do the same if you wanted to have a poor man's scleral profilometer, where you could put a spherical GP on the eye and see how the areas around the sclera are misaligned. But I just love being able to have my Pentacam AXL Wave and not having to do that. So what it's going to give us when we look at that CSP output is is all this data that looks like this. So let's walk through what all that means. Well, first we have our coverage map. This is going to show us how much of that 15 millimeter zone we were able to get. So we did pretty good in being able to get most of all of that 18 millimeter coverage. But if we didn't, we can always stitch it together. So this is an example of where we did one scan and then we stitched together the second one here. I really like to do that for patients that have really tight eyelids. So for this particular patient, when she just even slightly pulled down her lower lid, her upper lid, I just couldn't get out of the way. So we just decided to do one at a time. The next thing that we can look at are angle slopes and our sagittal height. Well, after we look at where that data comes from. So all of these cross sections here, all of these lines come from these Schleimflug images. And you can actually scroll here and look at the various sagittal heights as you click on these. I should have done a video of that to show it to you. And so then the next thing that we can look at is the sagittal height. So you can select your ring diameter here, and that's the diameter at which you can look at various sagittal heights. So you can toggle this up or down depending on what size of scleral lens you may decide to fit. What it'll do is it will show you your flat meridian and steep meridian. So it's just getting the sagittal height and essentially the least elevated and then the most elevated meridians and telling you the averages of those. But you can look at each individual quadrant here as kind of a quick look. It also shows you the sag height astigmatism, so what the difference is between the flat and steep meridians at that specific chord. It will then show you your your mean height, like your overall sagittal mean height when you take these two flat and steep averages. We'll talk about what we can do with that information when it comes to fitting diagnostic lenses. And then just kind of a different way to look at the information is the bulbar slopes, as we alluded to earlier. So this will show the same thing where we look at our flat meridian and steep meridian, the average slope at those particular meridians. Essentially, if you have a higher angle, that means that it's steeper. A lower angle is flatter. And then depending on the lens design, but typically about more than 3 degrees, you'd want to add some toricity to that lens. So we can kind of put all of that data together by looking at it as a whole now. So what I alluded to earlier is when we see this sagittal height mean value, if you were going to fit a particular lens, so for example, we'll go over a Zen lens diagnostic fitting. You can select how much clearance you would like on top of this cornea. So you'll add 300 microns to this sagittal height mean value, and you'd select a sag value of about 4,600 if you had somewhere around like a 15.4 millimeter scleral lens. And so what we haven't talked about is the coolest output of all, which shows you the general pattern of the eye that you're working with. So you have a best fit sphere of the cornea, which is in these dashed lines, and any deviation from that best fit sphere behind the best fit sphere is going to be negative, and then in front of it is going to be positive. And then you have a best fit sphere for the scleral profile. So anything negative is going to be behind it, and then anything in front of it, anything plus is going to be in front of it. So what do we do with this information now that we've broke it down? Well, let's look at let's go back to this one. This one is pretty symmetrical. We could put a quadrant specific lens on this eye and do pretty well. So I may look at some of my fitting guides for some of the lenses that you can use this information for, and have a really great initial starting lens that I can put on the eye, and then make, some small modifications from what I see behind the slit lamp, or just make sure that I agree with what the data gives me from my CSP analysis, and go from there. So you can really kind of empirically fit a lot of our more traditional scleral lens designs from this information and get to a first fit success relatively quick, because you know exactly what type of profile you're fitting. Now, if we were to see a sclera that looks like this, we could see that if we were to put in a quadrant specific design, we're probably going to run into some problems here. So if we were to say that one of our quadrants is here, okay, well, we can deal with that. That has, about 90 degrees of a particular pattern. But then 90 degrees or 180 degrees away from that, we're going to have some pretty significant misalignment. We're going to have maybe some edge lift over here, maybe some, blanching, or, too tight over here. And what the heck is going on in this area here. So this is going to be a really challenging fit with a traditional lens. And you probably wouldn't really know that until you're on visit number 4 of trying to figure out why in the world we're getting so much, conj prolapse or fogging, discomfort that we just can't fix. So this is just kind of a comparison of the two, of what would work really great from the beginning with our fit set, and going ahead and fitting them into a lens that we can physically see on the eye, or maybe choosing to do an empirical or a free form design. So for this particular patient, I went ahead and I made a wave lens for them. And so what I wanted to show you with this is that you can see right from the beginning when we look at the nasal sag here versus the temporal, there's about 900 microns of difference between these two meridians. And then if I rotate it around, it gets as high as 1200. So that would have been a really challenging patient to fit. And, you know, he was just kind of a simple keratoconic patient. I don't know that I would have looked at him and thought, wow, this is going to be a really challenging case, but it would have been if I wouldn't have known where I wanted to start and have had all of that information given to me. Well, what about this guy? That looks terrible. So he came to me and he was complaining of his eyes constantly being red. He used Visine about 5 times a day because he didn't want to look like he was on drugs all the time with his profession. And so I asked him to wash out of his lenses for about 4 days, prescribed him a topical steroid, lots of lubrication, and had him come back. And you can see he has a pretty big elevation there. Peaks at about 594 in this particular area. When you have pinguecula that are that big, it can be really challenging to fit them and to measure it manually, because you have to figure out, well, where is that lens landing on the pinguecula? What part of the lens is actually interacting with that pinguecula when you're doing your measurements? So I designed a ScanFit Pro for him. So all of that information goes directly into the ScanFit software. Here I'm just plotting his limbus here. And then it's going to compute the back surface. So I can just take a look at that, make sure that I agree for the most part with how it's looking. And then we get this beautiful lens. Typically when you submit it, the consultants will go in and kind of smooth out any rough areas for you. But that was a first fit success. I did have to change his prescription just a little bit. So he did technically have 2 lenses, but I really didn't have to change anything with this fit. And you can just see chef's kiss, like how beautifully that aligned over his pinguecula. So I was really, really happy with that particular case. You know, if you wanted to do it manually, like say you just had a patient that couldn't wash out of their lenses, this is a feature that I'll sometimes use in the iris retro image. It's actually used for like cataract surgeons. But I will measure exactly where the pinguecula ends and begins, and then you can put that into whatever software you want to make your vault, or, you know, in this example, it was a smart channel where I just put in the degrees in which it started and stopped. And you can also do it manually if you wanted to measure the overall diameter. This is also in the iris image view. A little bit more complicated, a little bit more mathy. And then you can use other tools like seeing about how tall the pinguecula would be with your anterior segment OCT. For other types of elevations that require really good precision, I love to use this data as well. So if you have like a bleb and it's very critical that you have very precise alignment over it, this is the CSP software is beautiful, a beautiful thing to have. What you find when you get to design these types of lenses is it's pretty wild how these lenses come back. You see just crazy shapes of these lenses, and then you get like a lens that is truly made for that patient's eye, which leads to you being able to maybe do really cool premium optics. Like if you wanted to do HOA optics, we have the Ovitz device. This is the Zen Lens Chroma that we designed their edges with the Pentacam data, and we had a very stable lens. So we were able to put the HOA optics into it. And that is critical if you're going to do HOA, that you have a lens that is not rotating, you know, at all. I think their threshold is like, you know, at most 2-3 degrees is at most what you want, depending on the particular HOAs that you're correcting. Also, prism optics. This is a Gaudy lens that we did with the AXL, the CSP software, and this patient had 3 prism diopters of base out. He's stoked. It's the first time that he's ever been able to go completely without glasses and see single. Other things that you can do is you can really, really fine tune your optics. You know, I feel like I have nightmares about multifocals, but at least with some of my freeform designs like Wave, I can decenter the multifocal optics based off of where maybe if the lens is decentered ever so slightly, like I just have full control of where I can put those multifocal optics. And this is just me measuring how far up and over I need to move the multifocal optics, courtesy of Dr. Dottie Fidel helping me to find out how to do this with my slit lamp. But also you can like decenter back optic zones. You can just do so many cool things when you have this type of capability. So let's go back to our friends that we measured earlier. After I get my scan, I'll just go through a little bit of education with them. Also, while I'm kind of taking note of their general corneal shape, what the thickness profile looks like, the elevation of the front and the back of the cornea. This particular patient had a herpes keratitis that ended up causing some irregular astigmatism. It's not too terribly significant, but he had monocular diplopia in both eyes, and conventional or soft contact lenses really just weren't working for him, and he was still seeing double monocularly. So I look at that, and then I'll go to my iris image, and I'll just kind of look at the HVID and VVID, see if there's much of a difference between those two things, because that will also determine what route of lens I will select. Then I like to look at their aberrations. So for him, he really didn't have a ton of higher order aberrations. We're at 0.3. So that was interesting to see, but typically when you have irregular corneas, you'll see that their HOAs are very high. And it's pretty interesting to see what those measurements look like before and after specialty lenses. If you guys have ever had a patient that you have fit into a GP or a scleral, and they go from hand motion to, you know, 20/20, a soft 20/20, but they tell you that they can't see anything. That's usually because if you look at the before and after of their aberrations, sometimes you can flip their aberrations in the opposite way of where they initially started, and their brain just cannot handle that. So that would be an interesting thing for you to be able to know through this aberration data. And then of course we have our my favorite thing here to look at, our corneal scleral elevation map. So he kind of had a pretty funky shaped scleral profile. We have this little elevation over here, which actually corresponds, no, it's over here, to this little elevation he had on his sclera. But you can see that, you know, maybe a quadrant specific lens would work, but his sclera is pretty irregular. especially as you start to look at some of these sag differences here at this ring diameter of a 15.4. There's a lot of asymmetry going on here. So this, if you want to scan this QR code, this will take you to some fitting guides that Oculus has available for different lenses, where you can either import some of the information from the CSP data, or just look at the CSP data and do some math on your own on what lens you may want to select from fit sets that you may have in your office, for example. So let's say that I decided to fit him into a Zen lens. The first thing that it asks is select a lens diameter based off of the horizontal white to white value. So the horizontal white to white is a 12.0. So it says you can either get a 17 millimeter or a 15.4. I chose to do a 15.4 because his cornea wasn't really anything too irregular, and he was a first time wearer. So I wanted him to be able to handle these a little bit easier. So then we set that ring diameter to that 15.4, and then we look at what our sag selection is going to be. So I chose to have 300 microns of clearance. So I'm going to pick a diagnostic lens that has about 4,400 sag. Now you can look at the bulbar slope values and get a good idea of approximately what your APS system would be. So you can see there's quite a variety there, from 30 to 44. So anything from a flat 8 to a steep 6. At this point, if I was to see that, I probably wouldn't even put a lens on him unless I needed to get a really accurate over refraction, because sometimes when patients have really irregular scleras like this, you can give them kind of a bad first impression of what a scleral lens will actually feel like when they get their custom one. So I went ahead and designed him a wave lens. And again, you can see as I kind of go through the different meridians here, how much these sagittal heights tend to vary. So about 1,000 microns here. I did that really fast. 600 there. So pretty big differences in each of those semi-meridians. And I also manipulated the base curve a little bit to where we could get close to plano to really not induce any sort of aberrations by having like a high minus lens, for example. Now, I really am just kind of scratching the surface of its capabilities of the Pentacam AXL Wave by talking about the scleral lens capabilities. But I felt like it was really important to talk about because it really has transformed the way that I practice. And there's just something so great about being able to dispense a first lens to a patient and just be spot on. I mean, it doesn't happen all the time, and I wish it did, but at least I can be close and make a very educated, precise decision on what route I want to go or what initial lens I'm going to put on the eye without having to do a ton of guesswork. And that can extend to corneal GPs as well. The Pentacam does an amazing job of getting all of the elevation data from limbus to limbus, where you can design really beautifully fitting GP lenses. I really have started to try to do a lot of more like intralimbal designs. This particular design was a design that I learned from Randy, Dr. Kojima, and Pat Caroline at I think it was at GSLS. And it's translated to patients being able to wear GPs and feeling pretty comfortable as initial GP wearers. We also have our myopia software, where we can show patients what their axial length looks like on a growth curve. This is great for education, for being able to tell parents where their children fall and that it's abnormal. We don't want to see them up there. We want to kind of slow that growth rate down. And then also to see how that annualized growth rate is looking when they come in for their follow-ups. You can plot on here like what treatments you're starting with, when you started them. This particular patient came to see me already on 0.05% atropine, and we prescribed him Ortho-K, and he's doing really well. Now his eye didn't get shorter. That's something that we see with some patients where their the choroidal thickening, but nevertheless, he's doing great, and we have an objective way to be able to determine that by performing optical biometry. We also have ways to determine if a patient is progressing with very, very high sensitivity. So this is the progression analysis where we have our thresholds for kind of like normal values of changes with the anterior curvature and posterior curvature and thickness. And then once we start to get into these confidence intervals, then we're starting to really worry about progression related to keratoconus. On that same note, I really like to look at the global pachymetry for my my patients that have corneal grafts. I'm always worried about fitting patients with corneal grafts and scleral lenses, especially those older grafts. I really love being able to have a baseline to be able to determine if we're getting any sort of, like subclinical edema and just staying on top of it before we have a problem on our hands. So in summary, we have all kinds of shapes and sizes of corneas that we see in our practice, and all shapes and sizes of scleras. And just being able to know exactly what you're fitting, like what route you're going to go, anticipating any potential challenges along the way has really transformed the way that I practice. And I appreciate being able to share that with you all today. So Dr. Tulo, I'm ready for some questions if we have any.
That is fantastic. And I recall when I started using profilometry for the first time 4 years ago, I thought I knew what the sclera looked like, and it was absolutely astounding how little I knew about the sclera by just looking at it with fluorescein and with scleral lenses on the eyes. I really thought I could predict shapes, and when I actually started seeing what the profilometry was showing me, it explains so many problems. One of the problems we have a couple of questions on is the good old midday fogging problem.
Mm-hmm.
How have you found profilometry to be effective or useful in reducing the midday fogging that we see in many patients with scleral lenses?
Yeah, that's a great question. And that example that we looked at earlier, where the areas where the sclera just got really steep, just didn't align with your typical like quadrant specific lens, and definitely not your toric lens. So within a particular meridian, maybe it's aligned really well, superior, inferiorly. Well, then superiorly, you have where it's kind of cut in half, where you have one half of the quadrant that is really steep, the other that's really flat, and we're just pumping up all kinds of debris underneath there. Being able to look at elevations in the conj, like sometimes I'll see it on the profilometry where I'm like, I didn't even know that there was an elevation there that I would have missed otherwise. Well, I would have missed that, and it would have been rocking, back and forth on the eye with blinks and causing fogging. But also another thing that I've started to pay a lot more attention to is the HVID as it compares to the VVID. And not paying attention to that during your design can cause a lot of issues where, regardless of how perfect your haptic is, if you have all of that misalignment right outside the limbus, you're going to get a lot of fluid pumped underneath too.
So speaking of that, Yeah, speaking of haptic designs, I know before profilometry, the exception was using a quadrant specific or freeform haptic design. And for me, since I'm using profilometry and looking carefully at this, I almost never not use a quadrant specific or freeform design. Can you comment on your change in your fitting habits since you've been using the CSP Pro profilometry?
Yes, same. I started looking at the data and started looking at my fits and was like, no wonder I had to see them back 3 times, 4 times, and they were having the same problem regardless of what I was doing. So yeah, I totally agree.
Would you also agree that now what you tolerate is a good fit is the bar has gone up now? Now you expect the fits to be much better than what you might have used to settle for maybe 4, 5, 6 years ago?
For sure. And it's so hard because I mean, when we're looking at the lens and the fitting relationship behind the slit lamp, it's really tough to know, should this be a 60 micron change? Should it be 90? What's going to happen when I change this curve? What is it going to do to
Period.
this curve that looks too loose right now? So there's so many
Yeah.
different variables.
And in the end, I think, I don't know if you agree with this comment, but I know the most frustrating thing for me is when you're on your third remake and the patient's not happy, you're not happy, or even you get your first lens and the first lens is not dispensable, which to me is an ultimate tragedy. When you go through
Uh,
the process of putting diagnostic lenses on without profilometry, and you go through that whole ordeal, and you spend a couple of hours with a patient, you order a lens, and then it comes in and it's not dispensable. To me, it undermines all the confidence that patient may have had in you, and it makes it such a more difficult uphill climb for me. And I found that that almost never happens anymore now that I really understand what kind of lens I need to order for which specific patient. Can you comment a little bit on your first lens success? And maybe you have to order a revision for optics or something, but as far as fit success, can you comment a little bit on that?
yeah. Yeah, I would say that my first fit success is, you know, I'd say it's very low for new wearers because I
Mm.
can just get there um, unaffected. Like I see their true scleral shape. I think what's really challenging are those patients that come in and they've already been wearing sclerals. You want to get them into a different design. I have a hard time asking people to wash out of their lenses because I know like how terrible it is, how they're not able to work, drive. But definitely for those new wearers, I'd say it's decreased my amount of visits by, gosh, or the amount of lenses that I'm prescribing. I wish I could put a percentage on it. It's been significant.
So cost of goods goes down, chair time goes down, all those things that affect profitability. Yeah, I think that was really the thing that it wasn't the reason why I started using profilometry, but it was a really welcome, nice thing. It made fitting scleral lenses for me a lot more fun.
Hmm.
I can remember not really enjoying a lot of the patient fits because of the time involved and having to convince them to stick with it, we're going to be successful. And now I feel like I don't have those conversations often anymore, which is a lot more fun. I mean, it's just being successful quicker and getting better final outcomes. I think I don't settle now for just good enough. I try to really get it the best it possibly can be. And having this data, as you mentioned right in the beginning of the webinar, having this extra data really makes, if you understand the data you're looking at, it really makes a big difference in selecting the right lens to begin with for these
Hmm.
patients. I've got
For
I've got
sure.
one more question to ask you. How do you use this, or do you use this as an educational tool for a new patient coming in for a fit? For example, I often will actually do a mock fit with them to try to differentiate my practice from everyone else around me on how they're going to, especially if they've been to other doctors and maybe they've failed and they're coming to me to try to succeed in a lens fit. How do you use it in your practice? Since you're like a specialty only practice, do you actually spend time with the patient, showing them the software and how you design it, or the data that you're collecting and things like that? How do you do that?
Yes, I do. So when right when we take the Pentacam and we see all of those beautiful Scheimpflug images, I tell them there's over 100,000 data points that are being taken, that were just taken of your eye. And so from this, I truly know, I know the exact shape of your cornea and your sclera. So by that time that I've kind of gone through that, the corneal scleral elevation map will pop up and I'll say, look how cool this is. This is not only the shape of your cornea, which, have you seen the shape of your cornea before? Sometimes they're like, yeah, I've seen that color map. I don't really know what it means. I'll walk them through that because I think it's really important that patients know why they see the way that they do. You know, just to understand better of why they can't wear glasses and being able to see. But then also I take it to the next step of, there are only a few practices in the US that have the capability to be able to see this amount of data and design a lens that is made for your eyes specifically. And yeah, so sometimes I will go ahead and pull up some software that's readily available to me. Wave is very easy to just kind of load into, just kind of go ahead and create a lens. And I do love showing them, like, there's all of these semi-meridians and I can change all of these tiny little dots to precisely where I want it to be to optimize your vision and your fit. And people are amazed, and just taking the time to talk with them about that. And it doesn't have to be you necessarily as the doctor. If your technician is taking the scan, they can also say something along those lines. If they've heard you say it enough, they can walk patients through what they're seeing, and people love it. It's kind of sad how many patients I've had that just don't really understand their condition. And they're just so appreciative to be able to have somebody take the time to explain it to them.
Yeah, and again, it's practice differentiator, and especially, I mean, even when you get away from sclerals and you talk about myopia management, parents really appreciate the difference that you can show them and how you're going to do this compared to how maybe they've been to other consultations for myopia management and they've seen other off-the-shelf kind of ways of doing ortho-K, and then they see this very customized way. I think when it comes to your children, and I know you have some children yourself, and you know how that feels. It's a comforting feeling knowing that it's a customized fit and that it's gonna be a lot safer and things of that nature. So I think the way that you do that, I love the big TV thing that you have in your office. That looks really awesome. I have one exam lane like that, but I think I'm going to do that in all my exam lanes after seeing how you did that.
Yeah, I got that idea from Stephanie Wu. She was like, you know, I have all this technology in my practice and patients just love the big screen TV and getting to see their images on it. So I have her to thank for that.
Yeah, and it makes it easier than instead of having to pulling them over to your 27-inch little monitor, having them on a giant TV screen, just standing up next to it. It's just a lot easier. They don't have to crowd into the monitor to see what you're trying to show them.
Yeah.
So I think that's excellent for patient education. Well, thank you so much for tonight. This was awesome. A lot of great information. If there are any other questions, you can continue to put them in the chat. We'll answer them offline. But I want to thank everyone for coming tonight, and especially a big thank you to Dr. Ariel Cerenzie for sharing her expertise with us. And have a great evening, everyone.
All right. Thank you, guys. Thank you for having me, Bill. I really appreciate it.
You're welcome. Take care.